or acute respiratory infection is the commonest cause of death among children in developing countries. In India, 20% of mortality under the age of 5 years is due to pneumonia, and 2/3 of deaths occur under the age of 1 year. Case fatality rates are high since access of majority of these children to treatment is limited. To reduce these case fatality rates, WHO adopted the standard case management. For management, categorization of cases on the basis of severity is required. For this, 2 signs, breathing rate and chest indrawing, are used. Pneumonia is recognized on the basis of fast breathing, while severe pneumonia is recognized by the presence of chest indrawing. You have to be well equipped with these 2 skills, and in the following film you will learn how to recognize fast breathing and chest indrawing. After the film, Dr. Harish will elaborate on these signs in context of pneumonia.
How to determine the appropriate case management strategy for a child with a respiratory infection.
उम्र कितनी है बच्चे की?
Second, how to assess a child aged 2 months to 5 years with a cough or difficult breathing. Third, how to assess a child below 2 months with a cough or difficult breathing. Fast breathing is determined by counting the number of breaths a child takes per minute. The cutoff point to determine whether or not a child or a young infant has fast breathing differs with age. For an infant below 2 months, 60 breaths per minute or more is fast breathing. For a child aged 2 months to 12 months, 50 breaths per minute or more is fast breathing. For a child aged 12 months to 5 years, 40 breaths per minute or more is fast breathing. You will now see how to count the breathing of a child aged 2 months to 5 years. Before beginning to count, make sure that the child is absolutely calm, because it is difficult to accurately assess fast breathing and other signs of illness in a crying child. Moreover, if the child is frightened, crying, upset or angry, the child may show signs which can be confused with signs of illness. To calm the child, give the child something to play with. Ask the mother to breastfeed the child, or suggest they wait in another room until the child calms down. Lay the calm child flat on the bed or in the mother's lap in such a way that you can look at the child's breathing and also glance at your watch while counting the breathing. Now look for breathing movements on the child's chest or stomach. This is breathing movement.
1, 2, 3, 4.
You can count the breathing
6,
without lifting up the
7,
child's shirt.
8, 9.
But it is
10,
always easier to
11.
count the breathing with the child's shirt lifted up. Now you are ready to
1,
begin the counting.
2, 3.
You can count the breathing by 2 methods.
6, 7, 8.
Method 1. Look at the seconds hand of your watch or digital watch and start counting the breathing.
1, 2, 3, 4, 5.
Occasionally glance at your watch. The count you have obtained is the breathing rate of the child per minute. Method 2. Look at the seconds hand of your watch or digital watch and start counting the breathing. In this method, you need not glance at your watch while counting. If the infant is less than 2 months, count 60 breaths. If the child is 2 months to 1 year, count 50 breaths. And if the child is 12 months to 5 years, count 40 breaths. After completing the counting, look at your watch again. If the seconds hand indicates passage of 1 minute or more, the child does not have fast breathing. But if the counting takes less time than 1 minute, the child has fast breathing.
After seeing this clipping on how to recognize fast breathing, let us now see how to recognize chest indrawing. Note carefully in this film the positioning of the child to recognize chest indrawing. Also note the timing during respiration, that is, whether indrawing occurs during inspiration or during expiration.
The best place to look for chest indrawing is upper part of the abdomen and the lower part of the chest. In normal breathing, the whole of the abdomen and the chest wall goes out when the child breathes in. But in chest indrawing, the lower chest wall moves in when the child breathes in. Therefore, every time the child breathes in, a clear groove forms between the abdomen and the chest. This is chest indrawing. See. This also is chest indrawing. Only if the groove appears every time the child breathes in, record it as chest indrawing. If only the soft tissue between the ribs or above the collarbone goes in when the child breathes in, this is not chest indrawing. See, this is not chest indrawing. This is chest indrawing. Here are a few examples of chest indrawing in children aged 2 months to 5 years. If there is any doubt about the presence of chest indrawing, reposition the child and check again. Ensure that the child is not bent at the waist. If the chest indrawing disappears with repositioning, it is not chest indrawing. Here is an example of bad positioning while looking for chest indrawing. A groove is forming both while the child is breathing in and breathing out because the child is bent at the waist. With correct positioning, the groove appears every time the child breathes in and flattens every time the child breathes out.
ARI has now become the leading cause of killer in children. If I have to see the recent data which is available with us, earlier it used to be diarrheal disease. Almost 28% of the mortality in younger children is related to pneumonia. Amongst the ARI cases, you rightly said, lots of children come to us with cough and cold. But amongst these cases, it's the detection of the pneumonia cases which is of paramount importance. It's the pneumonia children who is at risk of death. And death occurs very fast in these cases. At times, it may occur in first 24 hours. If a child comes to you with symptoms of ARI, which may be fever, cough, running nose, how to detect pneumonia, and as shown in this clipping, the two most important signs which are shown that which correlate well with radiological pneumonia are fast breathing and chest indrawing. Before you assess the child for fast breathing and chest indrawing, again let me remind that these children must be quiet, and against the common traditional pediatric practice of putting these children to breast for making them quiet, when you are examining for these signs, these children should not be sucking because that will interfere with your assessment. Again, if you can count the breathing rate without lifting up the clothes, one can count, but if you can't see it properly, then maybe it may be required that you may have to remove the clothes. If the child is sleeping, you can still continue with your assessment. And the two methods which have been mentioned, that if you are two people, one can easily do it. One person starts you and stops you. If you are just one person, take the cutoff point for the fast breathing and see whether 1 minute is completed or not. As far as chest indrawing is concerned, some amount of chest indrawing may be normally present in children below 2 months of age. It's only that when the chest indrawing is severe, you label them as cases of chest indrawing. In older children above 2 months of age, any chest indrawing is considered chest indrawing or a severe chest indrawing, and in these cases one has to be careful that child is not bent at the waist when you are examining. At times what is happening is that mother has put the child in her lap and she is holding the child by the waist, and that may obstruct your vision, and moreover chest indrawing may not come up. If there is no chest indrawing, make the child lie down and again have a look, and have a look mainly at the junction of the thorax and the abdomen. Don't go very near to the child. You can be at some distance, maybe few feet away, and only if it is coming with each of the inspiration. It should not be that it is coming at times and it is not coming at times. With each of the inspiration, if you are able to see the chest indrawing, yes, it's a definite chest indrawing.
Two more signs seen in children with ARI are stridor and wheeze. Stridor is commonly found in children with group syndromes. More the obstruction, greater is the stridor. Wheeze is a common feature in a child with suffering from bronchial asthma or acute bronchiolitis. These two signs must be assessed when the child is calm. Let us now see a film on how to recognize these two signs.
Stridor is a harsh noise produced when the sick child breathes in. To assess for stridor, ensure that the child or the infant is calm. Ensure quiet surroundings and listen carefully when the child breathes in. Holding your ear near the child's mouth will help, because it may be difficult to hear the noise otherwise. If you see stridor only when the child is crying or upset and not when resting peacefully, do not regard it as stridor. Wheeze is a soft musical noise produced when the child breathes out. To assess for wheeze, ensure that the child or the infant is calm. Then hold your ear near the child's mouth and listen for the wheeze when the child breathes out. Wheeze has one more indication. A child or an infant with wheeze expends much more effort and takes much longer than normal to breathe out.
The acute infections with stridor and wheeze are to be managed appropriately. For infections with stridor, oxygen, parenteral fluids and humidified environment is usually required. But in severe cases, hospitalization, oral or even parenteral antibiotics may be recommended. Dr. Harish, what is the treatment in wheeze? Could you also explain how a spacer is to be used and how to make an indigenous spacer?
In a child with wheezing, we may have to administer rapid-acting bronchodilators. Earlier, the modalities used to be subcutaneous epinephrine. Then came the discovery of beta agonists, especially terbutaline. But it's the aerosolized devices which have really revolutionized the management of asthma, because not only that you are using much less amount of the drug, but moreover the action is very rapid. You get the proper amount of the drug at the proper place. That is, you get very little amount of the drug and directly in the respiratory tract, which is responsible for producing symptoms. And now if you give the drug at the same place, you get very immediate relief. Spacer is a sort of a container. which is put between a metered dose inhaler and the mouth. You must have seen this device. This is known as a metered dose inhaler. If you press it, it releases some drug. This equipment is used quite commonly in adults. They may take it directly. But for taking of this drug, one may have to coordinate the breathing in as well as the release of the drug, which may not be possible in children at times. And that's why the spacers have been used more and more frequently. The spacer should be such that its capacity should be around 500 to 750 ml capacity. How to make an indigenous spacer device from the contents, disposable things of your daily use? You can use disposable ice cream cups, or you can use disposable plastic glasses, or you can use any disposable plastic bottles. In our daily routines, we get many of these plastic bottles which we may have used for administering IV fluids to these children. One can cut the bottle from the top. Like if I cut it from the top here, what I get is that a glass type of a structure. This is the place from where the child can inhale. Now for administering this drug with the help of this metered dose inhaler, I may have to cut it from the bottom for putting this into this. So I start cutting from here, and I have already prepared a hole for you, that I have made a hole like this. In this, I fit in my metered dose inhaler. For using the metered dose inhaler, one has to be careful that this is perpendicular. The side which is to be pressed is on the top. Before using, one must shake it vigorously and then put it on the child's mouth and press it. Like suppose this is the mouth of the child, I keep it here and press the medicine. The medicine comes here, and now let the child breathe through this for around 8 to 10 breaths, or roughly half a minute. Give one dose, one press of the metered dose inhaler, wait for half a minute, repeat the second dose. Again wait for half a minute and reassess the child. Majority of the children would have improved with this. If child has not improved, then you can go on to your next line of management, which may be use of steroids, use of antibiotics and other things.
Cough syrups are commonly used in cough and cold. Dr. Harish, what is your opinion?
Drugs are more often misused than they are properly used in children with respiratory infections. As far as pneumonia concerns, antimicrobials have to be administered, but your antimicrobial should be rational. But other cough and cold remedies, they may have lot of side effects. If I start with your simple nasal drops, they may contain ephedrine, which may give rise to convulsion and irritability in the children. They may also cause rhinitis medicamentosa, and moreover, there is a rebound congestion. So if you want to clear the nostril, one can simply use saline preparation and clean the nostril with a wick. For suppression of the cough, people have used many cough suppressants, preparations which may contain codeine and other preparations. They may have lot of respiratory depression effects. They may give rise to constipation. There may be other things such as mucolytics. Their efficacy hasn't yet been proved in children. There may be antihistaminic preparations which are most commonly prescribed in these cases. We all are aware that antihistaminics give rise to drying of the secretions, and then the cough persists for longer duration. Moreover, antihistaminics causes sedation in children, but one side effect which you may not be aware is that many of these antihistaminics causes irritability. We get lots of children in our inpatient department who have received antihistaminics, and now the child is crying constantly. And then you start thinking about various other differential conditions. What is simply required is that something to soothe the throat. Any traditional home remedy which is simple, which is cheap, which is easily available, and over which the family has a traditional belief can be used. Various people use various preparations of honey. They may add some lime in it. Some people may add ginger in it. Yes, you can go ahead with them. Some people use tea with tulsi leaves. Some people even use turmeric with milk. You can always prescribe those types of remedies which have some nutritive value, or even if they don't have a nutritive value, at least they are not harmful. But let me tell you that what plain simple warm water can do, no cough syrup can do it. If at the most you may have to use a cough syrup, and the only indications are if the cough is interfering with the feeding of the child, in that situation, one can use simple dextromethorphan containing syrups and not the syrups which contain multiple preparations. It's a waste of the medicine, it's a waste of the money, and you are inviting unnecessary side effect with them.
Vomiting is a common accompaniment of ARI. What do you feel is the cause of this vomiting?
Basically, it's the irritation of the throat. And irritation of the throat, if it is there mainly because of the infection of the lower respiratory tract associated with it, you may have to give antimicrobial. In older children, if you are suspecting streptococcal sore throat, if you give antimicrobials, the child will recover with it. Tell the child to take any warm liquids during these bouts of coughing, whatever is easily available, tea, coffee, milk or warm water, and let them have it. If it is interfering badly with the nutrition of a child, only in a rare situation one can use dextromethorphan. Otherwise, cough and cold syrups are simply to be condemned in these cases.
Recognizing acute respiratory infections are most important for management of these infections promptly and appropriately. The paramedical staff must also be taught about these signs. Chest indrawing and breathing rates are two signs which even the mothers can recognize. Health education talks and counseling can be used to create awareness among mothers so that these children can be brought immediately to a health facility for treatment.